Welcome to Lung Point-of-Care Ultrasound Module 3, Examining and Identifying Signs of Normal Lungs. In this DNP project, normal lungs refers to the dry, normally aerated set of lungs that are free of pulmonary edema, pneumonia, and pneumothorax. It is important to understand that even with the signs of normal lungs present, pathology may still exist in the form of asthma, COPD, or pulmonary embolus. It is therefore essential that the APP considers the complete clinical picture before making the final diagnosis. Module 3 objectives include identifying the 3 viewing zones and their associated lung lobes, identifying the PLAPS point and its significance, and recognizing the 3 signs of a normal lung: Alines, lung sliding, and the curtain sign. In lung point-of-care ultrasound, the chest wall is divided into the right and left hemithorax. Each hemithorax is subdivided into the anterior, lateral, and posterior viewing zones. The anterior zone lies between the sternum and the anterior axillary line. This region corresponds to and provides the best view of the upper lung lobes. The lateral zone lies between the anterior axillary line and the posterior axillary line, and this section corresponds to and provides the best view of the middle lobe of the right lung and the lingual region of the left lung. The posterior zone is situated between the posterior axillary line and the spinal column, and the posterior region corresponds to and provides the best view of the lower lung lobes. When examining the lungs with ultrasound, it's recommended that each of the 3 viewing zones per hemothorax be examined: the anterior viewing zone, the lateral viewing zone, and the posterior viewing zone. In addition, the entire length of the most posterior lateral wall, the posterior lateral alveolar pleural syndrome or PLAPS point, should be imaged because it often provides the highest diagnostic yield for pathology, and that's going to be this region right here with the red line, the PLAPS point. While assessing the PLAPS point, it is important to visualize and identify the diaphragm of each hemothorax, because that is the most dependent section and it's where gravity-dependent fluid tends to collect. And so it's going to be the most sensitive for pleural effusion. When examining each lung viewing zone and the PLAPS point, it helps to hold the transducer like a pen and to keep it perpendicular to the pleural surface so that what is being imaged corresponds to what is directly below the probe, and so that reverberation artifacts are created. If the transducer is not kept perpendicular, off-axis images may result and critical artifacts can be missed, which may lead to the wrong diagnosis. Furthermore, it is critical to hold the transducer over the intercostal spaces between the ribs, because the bone is very hyperechoic and will create shadows that obscure deeper views. Interpretation of lung POCUS exams relies heavily upon artifacts created by sound waves at or deep to the pleural line. Artifacts are false images seen during a POCUS exam that do not represent actual anatomical structures. When viewed from different angles or planes, artifacts disappear, whereas true anatomical structures endure. There are many types of artifacts, including reverberation, which includes the A lines, B lines, and ring down. Also, there's mirroring, refraction, acoustic shadowing, and acoustic enhancement. As you can see over here on this picture, I've got samples of several of these artifacts. Mirror artifact is when sound waves move through and reflect almost a duplicate image that's not actually there, but it produces a mirror artifact. Acoustic shadowing, sound waves hit this dense hyperechoic tissue, creating shadows below, kind of like what bones would do. Acoustic enhancement, sound waves travel down, reach the spot of anechoic where sound waves travel through quite well and produce this enhanced region below. Reverberation, such as B lines, you can kind of see a B, it looks like a B line here, which we'll talk more about in Module 4. And then refraction, so sound waves come down and actually refract and produce kind of this image off to the side. When performing a lung POCUS exam, it helps to keep in mind the anatomical structures that will be assessed. When a POCUS transducer is placed perpendicular to the chest wall over the intercostal spaces, its axilla beam travels through several layers of body tissues, including the epidermis and dermis, subcutaneous tissues, superficial fascia, deep adipose tissues, deep fascia, external skeletal muscles, external, internal, and innermost intercostal muscles, endothoracic fascia, parietal pleura, visceral pleura, and then into the lung tissue. Continuing on with a quick anatomical review, the two lungs are separated into 5 lobes, 2 on the left, a superior and inferior, and 3 on the right, a superior, a middle, and inferior, which are separated from each other by continuations of the visceral pleura, called fissures. The 5 lobes are subdivided into bronchopulmonary segments. These segments are divided again and again until the smallest compartment of lung tissue is reached, the secondary pulmonary lobules, which is this compartment here. Each secondary pulmonary lobule houses a bronchiole, numerous alveoli, branches of the pulmonary arteries, and pulmonary veins. The secondary pulmonary lobules are separated from each other by interlobular septa, these walls here. Normally, the interlobular septa cannot be seen with POCUS because it falls below ultrasound's resolution. Yet under certain pathological conditions, the interlobular septa becomes visible, such as in pulmonary edema. When viewing the lungs with POCUS, the transducer is placed in this area right here. This is the skin. So when viewing normal lungs with ultrasound, the epidermis and dermis are seen as a thin gray line near the top of the screen. Below that is the echo heterogeneous mixture of adipose tissues and muscles, which looks like shades of gray on darkness. Going deeper, the ultrasound beam hits the hyperechoic, parietal, and visceral pleura, which forms a single, bright, curved line. The pleural line is broken bilaterally by curved ridges with dark shadows below. The ridges are formed by the hyperechoic ribs that do not permit many sound waves to pass, which in turn creates those dark shadows below the ribs. When the pleural line, ribs, and rib shadows are viewed together, they form what is called the bat sign. The bat sign is used to orient the provider and to confirm that the single, bright, curved line is truly the pleural line. Identification of the pleura is important because misdiagnoses can occur when it is not correctly identified. Deep to the pleural line is the echo heterogeneous lung tissue, which appears as shades of gray flanked bilaterally by darkness. In lung POCUS, there are 3 primary findings that indicate a dry, normally aerated set of lungs, which include Alines, lung sliding, and curtain sign. If all 3 of these findings are present bilaterally in a dyspneic patient, then the differential diagnosis will be similar to those who have a clear chest X-ray, and will include things such as asthma, COPD, pulmonary embolus, an acid-base disorder, neurological disorders, neuromuscular disorders, or reduced oxygen carrying capacities disorders. A-lines, a finding in healthy lungs, appear as horizontal, hyperechoic, equidistant, descending lines that originate below the pleural line. They are best seen when the transducer is held perpendicular to the chest wall. A-lines represent reverberation artifacts created by the repetitive reflection of sound waves between the hyperechoic pleura and the POCUS transducer. The distance between each consecutive A line equals the distance between the transducer and the pleural line. A lines occur in dry, normally aerated lungs, and they signify the absence of pleural effusions, consolidations, or interstitial syndromes in the area being examined. And as you can see over here on the photos, this is the pleural line, transducer sitting up here, pleural line, and then these are A lines here, these hyperechoic, horizontal, equidistant lines. And again, down here in this photo, pleural line, A line, A line, A line. If one remembers, the chest cavity is lined by the parietal pleura, while the surface of the lungs are covered with the visceral pleura. Normally, the parietal and visceral pleura are separated by a microscopically thin layer of pleural fluid that reduces the friction between the two surfaces. Lung sliding represents the normal rhythmic movement of the visceral pleura as it glides along the surface of the parietal pleura during patient ventilation. On ultrasound, lung sliding appears as a regular, shimmering motion of the tissue below the pleural line. Lung sliding should always be present, and its absence indicates some form of pathology, such as a pneumothorax. Sometimes it may be difficult to identify lung sliding, especially near the apex of the lungs, or when a patient is breathing lightly. In this case, M mode, mentioned in Module 2, can be used to capture movements of the lung tissue over time to verify the presence or absence of lung sliding. If lung sliding is present, M mode will produce the seashore sign mentioned in Module 2. If lung sliding is absent, M mode will produce the barcode sign discussed in Module 4. And as you can see over here on this motion picture, you got the chest wall, the pleural line, and then you got lung sliding occurring below the pleura. Looks like a shimmering motion. And you can actually look in here and you can see an A line as well. In this next picture, this is using M mode. And as you can see, you got the seashore sign going on. You got the chest wall, which looks like ocean waves. The pleural line looks like the crashing waves or the shoreline. And then the chest wall in motion looks like a sandy seashore. The last sign of a dry, normally aerated set of lungs is called the curtain sign. The curtain sign is seen during inspiration at the base of the thorax, where the lungs, diaphragm, and subdiaphragmatic structures such as the liver and spleen converge. When the patient breathes in, the diaphragm moves down towards the abdomen, pulling the inferior aspect of the lungs with it. On ultrasound, the downward movement of the lungs appear as an impenetrable curtain that partially obstructs the view of the structures below the diaphragm that were seen mere seconds before. It signifies that the lungs have expanded and are normally aerated. And as you can see, this is the liver. You can see the diaphragm right here. And with inspiration, the diaphragm moves down and pulls the lungs, partially covering the diaphragm and subdiaphragmatic structures. And that is the curtain sign. Module 3 summary. Each hemothorax is subdivided into the anterior, lateral, and posterior viewing zones. The anterior zone lies between the sternum and the anterior axillary line, which provides the best view of the upper lung lobes. The lateral zone rests between the anterior axillary line and the posterior axillary line, and provides the best view of the middle lobe of the right lung and the lingual region of the left lung. The posterior zone is situated between the posterior axillary line and the spinal column, and provides the best view of the lower lung lobes. The posterior lateral alveolar pleural syndrome, Plapp's point, is located along the most posterior lateral wall of the thorax, and is significant because it often provides the highest diagnostic yield for pathology, especially for pleural effusions and lung consolidation. The three signs of a dry, normally aerated set of lungs include A lines, lung sliding, and the curtain sign. Alines are reverberation artifacts created by sound waves that appear as horizontal, hyperechoic, equidistant, descending lines below the pleural line. Lung sliding is the normal, rhythmic movement of the viscera pleura gliding along the surface of the parietal pleura during ventilation, and is seen as a regular, shimmering motion below the pleural line. The curtain sign is seen where the lungs, diaphragm, and subdiaphragmatic structures converge, and is the result of the normally aerated lungs expanding with the diaphragm, which partially blocks the view of the subdiaphragmatic structures. And these are my references, and I want to say thank you again for taking your time to help me with this DMP project. Please continue on to the post-test, and then on to Module 4, the last module. And we would like to see you at the Interactive Skills Workshop. It will be hosted at Southern Adventist University, and we'll have an ER physician who's been trained in POCUS there to help guide you through a point-of-care ultrasound exam of the lungs. To sign up, just go to the website's menu, click on the ISW scheduling, and sign up for a slot. All right, hope to see you there. Thank you. Bye.